So we got a lot to go through here. I'm going to go a little rapidly, trying to cover all the pediatric high-risk diagnoses and processes and how to be a great peds doc in a very rapid period of time. So let's go. We're going to, first of all, I have no financial disclosures, not on the take. I'm going to discuss who and why you get sued. We're going to review high-risk diagnoses, review high-risk behaviors on your part that can get you into trouble, and discuss lowering risk. There's lots of data about pediatric malpractice out there. Much of it won't be a surprise to you. The first big study was published on 15 years of data, looked at several thousand cases under age 18, found out that, not surprisingly, the kids under 2 are the highest risk kids, and those are the ones that really confound us. And most of the time when we make an error here in the PEDS ED or in your ED or clinic, wherever you're working, it's going to be an error of omission as opposed to an error of commission. You're going to miss the diagnosis. So we're going to talk about that. Fortunately, the pediatric malpractice only makes up about 10% of all suits. That's good. But the ED is frequently named in those suits. And why do people sue? Well, there's lots of reasons to be upset in the ED. First, your kid is sick. If your kid is sick and then your physician misses the diagnosis or your provider misses the diagnosis, those are a couple of strikes against you, but don't make them angry as well. So that's why we always have to be on our best behavior, communicate well, be nice, go above and beyond, get the kid the popsicle, the sticker, listen carefully, put on your best thinking face with the family. You want to triangulate, get everybody in the room, grandparents, cousins. You know how it is when you walk in those rooms, there's all kinds of people. Identify each and every one of them. I've gotten to be the handshaker now. I like that. I wash my hands a lot. That all makes people very happy. But nonetheless, even if you do everything right, you're going to get some people angry with you. Some people are trying to protect society from you. They're trying to get extra money from you. Or perhaps they feel guilty about what happened. But you cannot underestimate the whole Papa Bear, Mama Bear phenomenon, okay? That's the one thing that distinguishes a pediatric patient from other patients usually, is that there's this very, very intense protective element, and you have to respect that. You have to, those of you who are parents understand that, or grandparents, you have to be cognizant of the fact that there is a protector here and that you're treating the family as much as you're treating the child. The good news about pediatric cases is that most of the time they're settled out of court, over 90%. And money is paid and even fewer than that. It's only about 30% of cases. And if it goes to jury, you're usually going to win. Unfortunately, as you know, just to be named in a suit is to lose, right? And that's what we're trying to do here today, is to keep you out of the entire realm of litigation, because just to be named is to lose. It's the whole process. It just makes you question your existence on the planet, makes you feel terrible. You got a family that's angry with you. It's just not a good thing. So pediatricians do get sued quite frequently. About 27% get sued once, and several get, about 1 in 20 get sued more than once in their career. And what we've learned from that is documentation and communication is key. So fortunately, pediatric malpractice is only a small percentage of the entire pie. Unfortunately, financially, it's a big portion of the pie, as you can see by this graph. On a per-case basis, pediatric cases are paid out a larger sum. And why is that? Of course, greater damages because of longer time at work lost, pain and suffering. These children have longer lives to live. More support is needed for them. Of course, all the emotionality of seeing the devastated child plays into it as well. The cost of claims is higher and higher because of the long statute of limitations, the longer morbidity, as we mentioned, and the standard of care also in children is hard to define. It's hard to do good research in children, and so there's a lot of hearsay involved, a lot of expert opinion, and that can get us in trouble as well. So what are we missing? Well, usually it's a failure to diagnose. Because why? Because, there's lots of kids with febrile illnesses, lots of kids with vomiting, lots of kids with complaints, but only a very few of them have dangerous conditions, and it's hard to be good at picking up those subtle cases. No surprise, here's the list of the most common cases documented from that 20-year period. Meningitis, fortunately, is declining because of vaccines. Appendicitis also declining because of reasons we'll discuss, but they're still out there. Myocarditis and cardiac etiologies are increasing in frequency, and we'll talk about that a little bit. And then, of course, our old friend, testicular torsion. There's other diagnoses that you may want to look into, such as SCFE, dehydration, child abuse. All of these things can be very occult and challenging and is worth your careful study. So the contributors to diagnostic error are manifold and include, first of all, just missing the diagnosis. I mean, every kid with a headache and a sore throat can, on the worst possible hour of the day, look pretty sick to you. So eventually you see patient after patient like this, it can be difficult to distinguish the sick ones from the non-sick ones. So it could be from you delaying ordering a test or not ordering a test. It could be from miscommunication with caregivers. Be very careful about being definitive in your diagnosis in a febrile illness. These kids are evolving. They change over short periods of time. 4 to 8 hours can make a drastic difference. It's very important to arrange for close follow-up and to always leave the door open on these parents and children to be able to come back to you in short order if things change. If you're referring patients to another facility, make sure your patients that you refer get there and they know what you are worried about and the family knows why they're going in the receiving facility, knows why they're getting them. Tell them up front, I am worried about meningitis or whatever it is you're worried about. There's some more recent data coming out just in the last year. This is in the journal that I read most carefully, which is called Pediatric Emergency Care, or PEC. This was published by an undergrad actually named Glarum and Dr. Selpst, who's at the University of Delaware. He's been publishing on medical malpractice in children for 30 years. And the most recent data suggests that perhaps we're seeing a shift in the kinds of cases, and that now cardiac arrest or cardiac cases make up some of the more frequent and more dangerous conditions for you to miss. You can see down the bottom of the graph there that our friend testicular torsion and ovarian torsion in women probably make up a higher percentage, but cardiac etiologies are making up a greater and greater percentage of cases. Appendicitis still makes the list, although I think that's getting less and less frequent, and we'll talk about that. I've been more and more curious about cardiac etiologies, and I can answer questions on this. We just ran our 5-year experience at our facility, one of the ER residents at our facility over at UMC. We got together with some other faculty and some undergrads and looked at our 5-year experience with cardiac diagnoses. And if you look up this article, you'll be stunned at the kind of cases that we saw at our facility. And these weren't referred in cases either. These were just cases off the street, if you will, one of which included aortic dissection, B-type, that went to A-type, some kids with coronary artery abnormalities that presented with shock or VTAC. I mean, we've seen it all. So they're infrequent cases, but they do exist, so you should buff up your knowledge of cardiac etiologies in children. So let's look at a case here. This will bring it to the fore. So here's a 17-year-old boy this one was referred in from one of our urgent cares with chest pain for 3 days. Now, I don't know about you, but I'm seeing more and more and more chest pain. I don't know, back in the 80s when I trained, I just don't remember seeing that much chest pain. I think all this, cardiac awareness in families now, everyone has somebody with an MI in their family or some kind of condition. That has reverberated down into the pediatric landscape now. Kids know that dangerous things happen in your chest, and even though most of the time they're fine, they present with a lot of chest pain. So we see a lot of kids with chest pain, and the huge majority, just like the fevers, the huge majority are totally fine. So how do you separate the wheat from the chaff? That's the problem. So this kid's a classic example. 17-year-old kid comes in with chest pain for 3 days. The pain is worsening in intensity for 2 days. It's now severe and unremitting, severe enough that this clinic sent him to us. The pain is described as bilateral, both sides of the sternum below the nipple line. Not that unusual a description. But he's more comfortable with sitting forward, which always makes your ears go up a little bit. He's had no recent illnesses. He hasn't syncopized. He's not really short of breath. He can lay down. He doesn't have trouble breathing. So he's referred to us. On physical exam, nothing too dramatic. I mean, many kids with viral illnesses will present with these vital signs. Heart rate is a little bit up there, you can see. And I always get a little bit worried about heart rates to systolic blood pressure ratios. When it's greater than 1, I always put that in the back of my head, so that's the only thing there. He appears ill initially. He's pale and in pain. So now he's starting to fall into a little bit of a different category of chest pain. Most chest pain patients in children don't look ill to the examiner. He's got a normal cardiac exam, however, no rubs or murmurs or gallops. He's got clear lungs, normal liver. His pulses might be a little bit down, but he's mentating normally. There's his chest x-ray. Anybody worried? Looks fine, right? There's his EKG. Anybody worried? I know a lot of you guys are probably adult-trained people, and you guys can torture an EKG to a degree that I'll never be able to torture an EKG. But to me, this is I'm a pediatric doctor by training originally. This looks like a normal EKG to me. So, okay, EKG normal, chest x-ray normal, it's all good. He looks a little sick, though, so let's work him up, okay? So we get a troponin, nice. Reassuring troponin, that's good. White count, not too impressive, 11. The doc that saw this patient was an experienced doc, and he said, you know, I haven't seen too many ill-appearing chest pain patients, so I'm going to get a cardiology consult. Kiddo was given Motrin and triage, given a liter of saline. He gets a little bit better, but not better enough because he's still complaining of chest pain 2 hours later while we're waiting for the cardiologist to come in. Patient's given 6 milligrams of morphine to manage his pain. Patient improves dramatically, no surprise, with the morphine, right? And there, we'll take a look at his vital signs here. You can see when he comes in, he's tacky, as we mentioned. Pain score, 6 out of 10. Motrin doesn't do too much for him, so my buddy gives him morphine, and boom, there goes your pain score to 0, and your heart rate down to 92. So we're living large here now, right? Heart rate 86, all good. Blood pressure still a little on the low side, but the kid's feeling a lot better now. So he's observed in the ED for 6 hours. His vital signs and his pulses improve. He's out of pain now. His pain's reduced to 0 out of 10. And my buddy has a decision to make. So, because the kid wants to go home now. And this is the thing about adolescence. This is a thing to learn about adolescents. Adolescents, I either call them minimizers or maximizers, okay? So they either minimize their symptoms because they want to go to the dance that night, or they want to go to the amusement park the next day, or they got a date, or whatever the case may be. So they're either minimizers or they're maximizers, right? They're a little over the top with their symptoms, like as if you've got to blind yourself to that because the kids will just confuse you. Teenagers, in my experience, very few of them are straight on. There's always some other agenda, right? So that's the thing to be careful about. So this kid now, he's got his morphine on board, his vital signs have improved, his chest pain's gone, he wants to go home. And he's pushing my buddy to go home. So you sending him home? No, right. Because why? Because physical exam is the most important thing. And my buddy, who's seen a ton of chest pain, says when he walked in the door, he didn't look right to me. Okay? But doctor, because now you're treating the mother too, right? You got to treat the mother. Mother says, hey, he wants to go home. He's feeling better. His lab tests are all normal. His EKG is normal. His chest x-ray is normal. He wants to go home. My buddy, smart guy, nah, I think I want to watch him tonight. I want to keep him in. And actually, the cardiologist comes by and does an echo, and the echo is normal too. So now we're really in deep weeds, because now it's 11 o'clock at night. It's the middle of winter time. The ER is a mess. The place is screaming, and they want to get out of there and get a good night's sleep, right? But my buddy hangs in there and says, nope, you're staying the night. Here's your little pod next to the kid screaming with earache next door to you. So he's kept in the ED for 12 hours. There was no room in our hospital that night, as often is the case in January, and he's going to spend the night in the ER. Joy for all. So at change of shift, I come in at 7 o'clock, and I'm getting sign out, and at that point, the kid's admitted to the inpatient team, and this is always dangerous, too, because it's a handoff situation, but my buddy says, well, this kid's admitted in room 1C there. He's all tucked in to go to the floor. He just had some bad chest pain, was what the guy last night said to me. He looks better now, but he's going to go in there. And then at that moment, I get called to room 1D, one bed over, for a kid who's seizing. So I walk into room 1D, and as I'm walking into room 1D, the kid in 1D, seizures don't get me too worked up anymore after being in the ER for 30 years. So I'm walking into 1D, and yep, he's seizing. And over the side of my head here, I see this kid in room 1C, and he's going like this. ugh, and he's white as a ghost, and his heart rate is 130, and his pulses were terrible, and I was like, uh-oh. So the kid in the 1C, who's my chest pain from the night before, he's looking worse than my seizure patient in room 1D. And as I just said, he's just leaning forward, he looks uncomfortable, his heart rate's up, boom. So we got a chest x-ray. So what's going on there? Well, dissection is a good, not a bad thought, but he isn't actually the patient. This patient did make our little study criteria, but he is not the dissection. But a dissection would look like this. You're right, a B type progressing to A type. But no, this kiddo had a massive pericardial effusion, and that was totally negative the night before. And his crushing chest pain was his pericardium literally stretching right in front of us, which we ablated with our morphine and Motrin and fluids, and minimized our teenager who wanted to go home. But luckily for my partner, he kept him in overnight and off to the cath lab. We gave him some fluids, his pulses got better, we gave him some more morphine, he felt better, we calmed him down, and he got a pericardial window and had 700 cc's of fluid drained from his pericardium. Oh, well, there's his effusion. See that big black rim there around his, oh, there you go. You can actually see you're getting a little tamponade phenomenon there too with his intraventricular septum. But he did not get tapped into ED despite my ED colleagues running around the hospital looking for the largest needle in the hospital. They literally were running around looking, get us the largest needle in the hospital right now. But no, we didn't tap him at the bedside. He stabilized and went to the cath lab. So what's the lesson here? The lesson here is be a clinician and don't worry about your tests. And this is a metaphor for just about any pediatric case you see. Use your initial impression. Each patient you walk into, and I know it gets boring in the wintertime, one after the next, vomiting, diarrhea, cough, cold, fever. But that denominator that you're building up, that denominator of normalcy, that denominator of what constitutes a usual viral illness is a denominator that's going to be able to say, oh, this patient belongs in the numerator because this patient is different because this patient looks sick to me. Yes? Influenza B. Yeah. So we all read the papers, right? And we see, because we all see influenza like crazy, right? We see all, and we say, how do these patients die, right? It's because one of them gets this. And, eventually goes into left ventricular failure because of tamponade physiology or goes into an arrhythmia or whatever. And that's how they die. Something physiologically aberrant occurs. So this kid was just weeping pericardial fluid. Think of your heart. You've all seen like cellulitis in your extremities, right? When you get an infection, it gets big and boggy and sometimes it weeps. Well, your heart muscle can do the same thing if it gets infected. Luckily, it's protected most of the time, but it can also get inflamed, boggy, and weepy, and boom, there you go. Organ failure. I'm sorry? Yeah, it was normal. I don't know. I think his repeat was abnormal, but his initial one was normal. So that's the point that I'm making, is that it's a spectrum, it's a course. Patients change. Be careful. See each patient anew, and it's difficult to do with kids because you walk into every room and the history is the same, right? Fever for 3 days, threw up 4 times, had diarrhea last night, complaining of stomach pain. It's the same thing, right? Every time. So how are you going to learn to thin slice this and not make your Gladwellian mistake, if you will, of thinking everything is the same? How are you going to get your 10,000 reps in to make sure that you know who belongs in the numerator and not the denominator as just another viral infection? So pericardial window, in the cath lab, he makes a full recovery. Okay, let's move on to fever, because most of these things, as we said, are going to be fever. So how are we going to get, most of these presentations are going to initially be with fever. So you're going to have to become expert in fever to be really good at not missing a high-risk diagnosis in children. Because all the bad stuff, most of the bad stuff, presents with initially fever. Because they're going to think about sepsis, meningitis, pyelo, pneumonia, but of course meningitis and sepsis are the big ones. So what's the single biggest indicator of a child with sepsis? Is it white count, height of the fever, CRP, child's appearance, procalcitonin level? Answer? Child's appearance, okay? I love it when I walk into a room and the chief complaint is fever of 104.5. And it's busy, the place is rocking, you're 10 patients behind. You walk into the room, and this is like a gift from God right here, right? It's like, thank you, Lord. I can just do my little, little show and see you later, go to your doctor tomorrow. That's great. But unfortunately, this is not what we get. But this is why you've got to become a little bit of a showman in your pediatric practice. You've got to make the kids smile, get your toys, get your puppets, make a fool of yourself, make funny noises, something to get this kid to say to you, I'm okay. Because, right, no one walks into this room and gets worried, right? So that's what we're looking for. So not the white count, not the procalcitonin, no. We're looking for this. So always be careful with the vital signs, though. Even in a patient like him, you got to be careful. Make sure if it's a sick patient that you get your nurses or staff to get your vital signs repeated, and make sure you document the blood pressure in sick appearing kids. Most of the time when med mal occurs and you lose, it's because vital signs were not documented frequently enough or abnormal vital signs were missed. There are some unbreakable rules in pediatrics. If the baby is 28 days or younger and has a fever, whether it's a fever in your department or a fever at the home, do a full workup on that baby. So full septic workup, admit, and empiric antibiotic therapy. And documented fever at home is a fever for you. I would not get a shortcut around that. And if you're not comfortable managing that, send it to a place that they are comfortable managing that. I would refer to algorithms in the 29 to 90-day age group. There's many of them out there all over the internet. I particularly like the one at Mercy Children's in Kansas City. If you go to your app store and put in Mercy Children's, there's an app, a pediatric guide app that has an app that will take you through step-by-step how to manage fever in that age group, and I think it's a good one. It's as good as any other one. Use a period of observation and serial exams to document over and over and over again. I don't know, how many people have Epic here? Epic? You know you can put pictures in Epic, right? So if you can get a kid to smile for you or play for you, or you can even put video in Epic now, the most recent versions, take a picture of the kid. And that way if the kid the next day has sepsis or whatever, you just go, there it is, look at, this is what he was doing. He was taking a popsicle 22 hours ago, because that's what happens. That's what happens. I do it all the time now. Don't miss meningitis. Okay, this is the biggie. You're going to have to LP a lot of patients with negative CSF. There's just no other way around it. I don't care. I've been doing this 30 years. I still get more negative LPs than anybody in my group. Why? Because I don't want to miss one case of bacterial meningitis, because that's a game changer, right? You miss, and we'll go through this. If you miss bacterial meningitis, your career will never be the same. Neither will the child, unfortunately, most of the time. So we cannot miss meningitis. The single best test ever invented, the lumbar puncture. If you're not good at it, send it to somebody who is good at it. So if you have a patient who's irritable, overly sleepy, is described as different by the parent, and is different for you, get an LP or send him to somebody else where the patient can be reassessed. Anybody with a bulging fontanellen fever gets an LP. Many of those are viral as well. Doesn't matter. So time is important in those little kids with fever and kids with irritability. If you don't have a sepsis algorithm in your ED or clinic, then create one. Get those patients sent back to triage, from triage to your beds faster. Time does matter. Whenever you see a meningitis or a sepsis case, time is the thing that comes up in every instance, and we'll go over some cases of those. Don't delay antibiotics because you can't get the LP. Give the antibiotics. There'll be an ID person 2 days later that's cursing your name. Doesn't matter. If you give the antibiotics, you have done the right thing if you're worried that this patient is septic or meningitic. Let the ID people curse you up and down. It's no big deal. Always order a fluid bolus. It will help with these cases. So here's one. 8-week-old who's fussy, not eating well. He's got normal urine output, no rashes. He's got abnormal vital signs. His white count is a little up. He's got some bands. He has a positive UA. Okay, but don't be tricked. Give him antibiotics and fluids. Would you do an LP? Well, some people say, well, he's got a UTI. Well, I don't care. If he stays tachycardic and he stays highly febrile and he stays ill-appearing, get the lumbar puncture as well, because the treatment course is different. At the same time, the problem with our pediatric practice is that we have to be extremely vigilant not to miss the bad stuff, but simultaneous with that, we don't want to put everybody scurrying around as if every single fever is bad. Fever is not physiologically necessarily bad for you. It probably has a teleologic reason that it exists. It probably helps get rid of some part of the infection. All fevers do not require antipyretics. You don't have to beat down the temperature with a stick. The higher the fever, the worse the disease. Not true. Many cases of viral illness have extremely high temperatures and the kid will be totally fine. Alternating Tylenol and Motrin is not recommended as a standard of care by any authoritative body. And not all fevers require a blood culture and a CBC. But you have to learn from experience, patient after patient after patient, which kid is right and which kid is not right, and follow your gut, get other opinions, and use serial exams. So CBC not needed in every patient, and also CBC that is normal does not rule out bad stuff. So it's crazy that we rely on it so much, because you can have an entirely normal CBC and still be septic, still be meningitic, and it will not keep you out of court. So who's high risk with fever? Kids that don't look right, as we discussed. Kids that are not acting right. Beware the somnolent child. If you're the unfortunate person who is the nocturnus for your group, just be careful, because I've had residents do this too, where the patient's 3 o'clock in the morning, but he's sleeping, doc. I don't want to wake him up. Well, wake him up if he's got a fever. Make sure that he's mentating. Make sure he's fixing and following and is not irritable. Meningitis can present as somnolence. It's a very challenging time, 2 o'clock in the morning. Be careful if the patient's not fully immunized, if the fever's been going on for a long duration, or obviously if the patient has petechiae with his fever. It's probably better off just give them a dose of antibiotics, get a blood culture, and watch them for a while. Okay, here's another case that makes us concerned. 12-year-old boy with fever. Comes in with 102 fever, and he had a 3-minute tonic-clonic seizure. He's postictal or sleepy for about 25 minutes. Now he's awake. He's got a mild headache, but he doesn't look too bad. He's not had any vomiting. He's not taking meds, no known ill contacts. His vital signs are abnormal here, obviously, but they don't really make me too concerned. I mean, every kid with a virus has this too. He has no nuchal rigidity, so he can't have meningitis, right? Wrong. You can't have meningitis without nuchal rigidity. White count's 15. He's got a bandemia. His UA is negative. The diagnosis of the physician is simple febrile seizure. Is that right? Is that a simple febrile seizure? Gentleman in the 5th row? No. Simple febrile seizure is not a 12-year-old. Simple febrile seizure is defined by the experts as being brief in duration, less than 10 minutes in duration, occurring only once in a 24-hour period. So if you repeat a seizure in 24 hours, that's not simple. A focal seizure is not a simple febrile seizure. You can't look meningitic, and you must be between the ages of 6 months to 5 years. So this doc said, oh, simple febrile seizure, kid, 12 years old with fever. Wrong. That kiddo returned 8 hours later in status epilepticus. He was neurologically devastated, and the case settled for $1.5 million. So you have to, if you're going to use terms that are used by, experts in the field of pediatric neurology and infectious disease, like simple febrile seizure, well, you better have read the guideline and know how to distinguish one from the other. 11-month-old with fever and vomiting. 3 days of fever, vomited 4 times today, no diarrhea, some URI symptoms, decreased urine output, no past history, febrile, tachycardic, looks slightly dehydrated on exam is the way they describe the patient. He's given IV fluids. He failed his first oral fluid challenge. He's given a second fluid bolus. He vomits on the second time a little bit, but looks a little better, so home he goes. Returns to the ED 8 hours later by EMS, having a generalized seizure. He's got markedly abnormal vital signs on this occasion, as we see there, 104.7, 185. RN describes him as sleepy or postictal. The doctor says, well, he was here earlier with fever, now febrile seizure. No neuro exam is documented. Parents push back on getting an LP, and they agree to the CT. Let's get a CT, and let's do a CT before LP. So then the LP is delayed. The doc signs it over to the next guy, says when the CT comes back, if it's normal, do an LP. Then the next guy says CT normal, we'll admit to pediatrics, let the pediatric resident do the LP. Bad idea. They do the LP 7 hours after the presentation, cloudy CSF, bacterial meningitis, antibiotics were delayed by 7 hours. Patient has a rocky course, survives with moderate neurologic sequelae. Lawsuit arrives, and of course you can get a plaintiff attorney to say just about anything, and they decided, the jury decided for the plaintiff in this case. So the lesson is here, do your own lumbar puncture. You don't need to wait for a CT to do the LP. You don't need to wait for the CT to give antibiotics.